Well, hi everyone, Dr. Kelly here. I'm here with the Dr. Eddie Atwood, and we're going to pre-record a session on EKGs. Why? For two reasons. One is that so when you go into your small groups, you can focus on just doing those 19 EKGs. We're going to get the PowerPoint out of the way. And what's the second reason, Dr. Atwood? Yes, it's because we love you, and that's why we're here on a Friday night doing this recording. All right, but before we begin, you're going to have a 3-minute pre-test. So I'm going to show a QR code. You're going to pause the video, jump to the QR code on your phone, and you're going to describe these 3 EKGs, just a quick diagnosis. You have to do it in about 3 minutes, because if you submit more than 3.5 minutes late, they all count as wrong. And don't worry about it. This is just a pre-test, so we can see how much you learn between this PowerPoint and the small group session. Okay? So pause the video. Do this QR code on your phone. You can expand the pictures if you want to get a better look at the EKGs. And then we'll come back here when you're ready.
I just want to say what a privilege it is to talk with you, and welcome to the wards on the clinical side of medicine after completing an arduous 1.5 years of basic science and introduction to clinical medicine. It is a privilege to do this. I remain grateful to Bill, and what I want to send a message to you is that you really are the best thing to happen to medicine, and to have that humble confidence to pursue knowledge and ask questions and question dogma and what I call courageous learning. As you've learned, the heart has inherent electrical properties. Spontaneous depolarization of the sinoatrial node leads to a signal that then propagates down the atria to the AV node, down the His-Purkinje system to the ventricle, and this propagation leads to depolarization and mechanical contraction throughout the heart. Now, once depolarization completes itself, the cardiac muscle repolarizes and is ready for the next wave of depolarization. The sum of these myocyte potentials are really measured on the surface electrocardiogram that allows us to look at the rate and various depolarization and repolarization patterns that may suggest either illnesses or abnormalities in the cardiac system. When looking at electrocardiograms, there are various approaches, but if I had one single commandment, it would be systematic. Approach the EKG in a similar fashion each time. That will allow you not to forget certain areas and not anchor too quickly on a diagnosis, but rather look at all of the aspects. This is probably a life lesson. Anyway, the interpretation algorithm that most people like, and I like in particular, is to first look at the rate, and then the rhythm, and then the axis, and then look at the intervals, the PR interval, the QRS, the QT, and the corrected QT, and then to look at the morphology. In addition to the systematic approach, you want to consider the clinical context. So whenever possible, find out the information about the patients when you are about to read it. If not, sometimes you're just faced with the EKG by itself. Find an old EKG is the third commandment, so that you can compare any changes that might be abnormal with a previous EKG that may show the same abnormality. Fourth commandment, beware of bad data or artifact or misplacement of leads. If you don't have a diagnosis, remember that you can describe what you see and know, and sometimes that's enough for a cardiologist to help you make the diagnosis. Last but not least, don't be afraid to get help. Cardiology loves medical students and happy to help at any time. So the lead systems that you're going to learn are the limb leads and the precordial leads. They were placed there to kind of give us a sense of where the flow of electricity was going or any abnormalities morphologically or intervals that we're going to look at later. The limb leads are the ones that we put on the left arm, the left leg, and the right leg. And we record from these in a bipolar fashion with the limb leads, and then we do augmented leads besides. And the precordial leads record depolarization from the center of the heart to the chest wall. These limb leads, the right arm, left arm, depolarization gives us 0 degree depolarization straight across the chest. Then the right arm, left leg gives us a 60 degree depolarization approach that we'll see on the EKG when we determine axis. Lead 3 is left arm, left leg.
The augmented leads are AVR, positive 210 or minus 150, AVL, which is minus 30, and AVF, which is positive 90. This therefore gives a full frontal plane axis of which you can calculate vectors.
Now the precordial leads are what I call the deceitful leads of cardiology because they're so hard to put in the right place. And so it's important to recognize that depending on whether there's excess tissue around in heavy people or whether somebody's miscounted the number of interspaces, but the leads should be placed. The V1 is in the fourth intercostal space to the right of the sternum. V2 is put in the fourth intercostal space to the left of the sternum. Then V3 is placed on the fifth rib, and V4 is the other major placement that we use, which is in the fifth intercostal space along the mid-clavicular line straight down here. And then from that point on, you go straight down the chest wall along the anterior axillary line right here is going to be V5, and V6 is going to be mid-axillary line. Now, I've had people put leads all put V1, V2, V3, V4, V5 all in a row, and that's not correct. I've had them use the costal margin, and that's not correct. And I've even had one person place it on the right precordium. Now we use that occasionally if there's an inferior myocardial infarction, but the leads should be placed on the left precordium first before venturing into the right side. Now there are certain conventions that you're going to see in terms of the electrocardiogram at what voltage or what paper speed. These are seen to the left of the electrocardiogram, and when we start interpreting them, I'll point out that standardization. But 1 millivolt is represented by 10 millimeters of height on the y-axis. So each millimeter is 0.1 millivolts. By convention, we use this as millimeters. We describe on morphology that there is 2 millimeters of ST elevation, not 0.2 millivolts of ST elevation. In research papers, sometimes they will present that. Now the paper speed is normally at 25 millimeters per second. So in other words, the paper flows at a rate such that if you have one big box or 5 millimeters, that's 200 milliseconds. And 1 millimeter is going to be 40 milliseconds. And needless to say, 5 big boxes is 1 second. So that's how we look at the paper speed as well as the voltage. Now, the P's and Q's of electrocardiography are not particularly complicated, but they're statements that we will make that may be a little confusing. Needless to say, the P wave represents atrial depolarization, and the QRS represents ventricular depolarization, and the T wave represents ventricular repolarization. But what happened to the P wave repolarization? Well, that tends to be hidden in the QRS right here. Now you're going to hear terms of segments and intervals. So I want to clarify that intervals is a time phenomenon. So in other words, the PR interval begins from the P wave to the onset of the QRS, which sometimes can be the Q wave, but most times you'll hear the PR interval, but it's the onset of the P wave to the onset of the QRS. Now the QRS begins with the onset of whatever major wave is there, the Q wave, which is the initial negative depolarization, or the R wave, which is the positive depolarization, or the S wave, that is the negative depolarization, and it ends at the J point. So the QRS begins with the onset of the Q wave or the R wave, and then ends with the J point. Now, the QT segment, or I mean the QT interval, begins with the onset of the QRS, and it goes all the way to the end of the T wave, not to the U wave, which is the M fibers repolarizing, but this T wave ends here, and we have the QT interval from the onset of the QRS to the end of the T wave. Now, because it's so rate dependent, we have what's called the corrected QT interval, and it's a very important interval to remember. 450 milliseconds is probably a nice number to remember and an easy one. If it's greater than 500 milliseconds, then you have to be worried that there could be toxicity or something significantly wrong with the repolarization. Now the segments are different. The PR segment is a morphologic statement of the end of the P wave to the beginning of the QRS. And the ST segment is the onset of the J wave, from the onset of the J wave to the beginning of the T wave. And those all have morphologic importance and significance. Now, when we look at the EKG is 10 seconds worth of information that goes across here, and we have limb leads, and we have precordial leads. Each one of these leads, lead 1, 2, 3, have 2.5 seconds of information. AVR, AVL, and AVF also 2.5 seconds of information, and so on through the precordial leads, which are V1, V2, V3, V4, 5, 6. Now the rhythm strip here is usually one rhythm strip, and usually it's lead 2 because it gets the best look at the P wave and atrial conduction, but sometimes there are 3 leads, and those 3 leads are usually lead 2, lead V1, and lead V5. But it all depends on the format. Now, when we start looking at the EKG, we've suddenly started at looking at the rate. So the way we look at the rate is we look at, there are various ways of counting it. So the standard way is the RR interval and the number of big boxes within that interval. Now, big boxes means 5 millimeters, and you see it right here. And this is 1 big box, 2 big boxes, 3 big boxes, or 4 big boxes. And if you divide 300 by the number of big boxes between the RR interval, you will have the rate. For example, if you have an RR interval that's only one big box, it's going to be 300. If it's two big boxes between the RR interval, it's 150. Three big boxes, 100, which is the upper rate of normal. Four big boxes is 75. And five big boxes is 60, which is the lower limit. And a heart rate of 100 is tachycardia, in other words, less than three big boxes. And a heart rate of less than 60 is bradycardia.
Other ways to calculate the heart rate, one of the simplest is just to count the number of QRSs on the electrocardiogram, counting, which is 10 seconds. So you count 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So 10 times 6 is 60 beats per minute. Now, why did I use 6 and not 10? Because it's 10 seconds worth of data, and 10 into 60 is 6. Now, when we look at this heart rate here, it's obviously slow. And you could count the number of big boxes between the RR interval and come up with a number. But I prefer using the number of QRSs since it's so easy. 1, 2, 3, 4, 5, almost 6. So 6 times 6 is going to be a rate of 36. Now, I wanted you to look at this because this EKG is so slow, and sometimes we can look at P waves here that do not always have the same relationship to the QRS. And we'll be talking about those rhythms of bradycardia and kinds of heart block in the next few slides.
Rhythm is very important. Rhythm basically says, is it regular or is it irregular? But that's just an adjective. Is it fast or is it slow? Again, another adjective. But you will hear terms like sinus bradycardia, sinus tachycardia. You may hear heart block. You may hear atrial fibrillation. All of these are rhythm terms of diagnoses. The regular and the bradycardic and tachycardic are just adjectives. Is it narrow or wide? This kind of gives us some clues to where the beats are coming from. If it's narrow, we know that the His-Purkinje system is intact, and that means that the AV node is conducting down through the His bundle, down through the His-Purkinje system, so that this will be above the ventricle. Now, wide, we're going to discover may be both supraventricular, in other words, above the ventricle, and narrow, or it may be in the ventricle itself. And so that leads us to a conundrum and how to diagnose this. And that takes looking at the EKG and a whole different topic. We'll talk a little bit about a couple of these in the coming up. Now, if it's regular or irregular, again, we look at whether it's wide or whether it's narrow. Classically, if it's an irregularly irregular rhythm, we think of atrial fibrillation. If it's regular or regularly irregular, we may look for premature beats, either being ventricular or supraventricular. Now, sometimes if we have a fast rate and it's regular, it doesn't have to be sinus tachycardia. It can be many other things. AV nodal reentrant tachycardia, atrial flutter, all of these. So regularity, whether it's narrow or wide, and whether it's fast or slow, are the big things to look at on the EKG. Rhythm. How do we define sinus rhythm? And sinus rhythm, you'll hear people say that it's a P wave before every QRS and a QRS after every P wave. But I want to dispel that concept, because really sinus rhythm is just the SA node firing and moving down the atria in a normal axis and then going to the AV node. And that means that the P wave axis is very important. And here we have that. That P wave should be upright in 1 and 2, maybe even in AVF, and negative in AVR. So it's got a normal axis coming down, and we're going to talk about axis in a minute. But the P wave is really the marker for sinus rhythm, and then whether or not there's a P wave before every QRS and a QRS after every P is nice if it's normal, but we can have sinus rhythm with complete heart block. We can have sinus rhythm even in ventricular tachycardia. So this is a complex phenomenon that needs close look at later. Here are some examples of AV blocks, which are frequently determined by the intervals between this. For example, first degree AV block is the interval between the P wave and the QRS. And if it's longer than 200 milliseconds, then we call it first degree AV block, and then if it's less than 120 milliseconds, we get worried that it's too short of a PR interval and may be related to Wolff-Parkinson-White or a short PR and supraventricular tachycardias. Now, second degree AV block has a certain amount of irregularity to it, and we have, with type 1 second degree AV block, which we used to refer to as Vanke block, but sometimes we call it Mobitz 1. But the true terminology now should be type 1. The PR gets longer, so here it's getting a little longer, and then there's a non-conducted P wave, followed by again the regular sinus rate, and then the PR is shorter. Now notice with type 1, the PR is shorter than the last one before you have that dropped beat. So we have PR prolongation, we have the PR post-drop is shorter than the one pre-drop. Then we have this interval here between the RR interval is less than the interval between the two PP intervals. So this is type 1 second degree AV block found in athletes, high vagal tone, and that. Now type 2 is different. Type 2, or Mobitz type 2, which we referred to years ago, is a fixed PR in which the PR interval is the same, and then you drop the beat, and the PR post-drop is the same as the one pre-drop. This means that the RR interval here is a multiple, an exact multiple of the 2 PP intervals, or it could be 3 PP intervals. This indicates conduction system disease that is highly significant. And notice how the QRS is a little wide, which indicates also conduction system disease.
The axis is a difficult concept to understand, but if you look at the heart and you think of it as having a center here in the middle and looking at AVR, AVL, lead 1, lead 2, and the augmented leads AVF and also lead 3, we can calculate the general depolarization pattern from the base of the heart to the apex. Now, we call that the axis, and the axis we use leads 1 here and leads 2 here to determine whether it's deviated to the left, which would be more negative than minus 30, or to the right, which would be more positive than 100.
If the QRS is positive in 1, in other words, it's going this way, and if it's positive in 2, then it's going down this way, then it's normal. The USU students taught me that if you use your thumbs like this, and the left thumb is lead 1, and the right thumb is lead 2, if it's negative in 1, down this way, and positive in 2, it is right axis deviation. If it's positive in 1 but negative in 2, it is left axis deviation. Now that's a simple approach and probably too simplistic, and I would be frowned on by my cardiology colleagues to have ever shown you that trick, but sometimes it helps. This slide demonstrates a positive in 1 and a negative in 2. We know that if it's positive in 1 in your left hand and negative in 2, that's the same as left axis deviation, which are associated with LVH, left anterior fascicular block, and possibly inferior MI.
Now, if we look at this next one, what is the axis here? Now you see that it's negative in lead 1. In other words, the S wave is far greater than any R wave component, making it negative in 1, but it's positive in lead 2, so that would be right axis deviation. So let's use this thumb technique. If it's negative in 1, so thumb is down, and it's positive in 2, so it's going to be right axis deviation. The thumb that's up says which axis it is. So right axis deviation. And causes of right axis deviation are RVH, left posterior fascicular block, and pulmonary embolism. Now, why do I put pulmonary embolism as important there? Because you never want to miss a treatable disease in medicine.
Now, we're going to look at the intervals, and we talked about the difference between intervals and segments. The PR interval, the onset of the P wave to the QRS is right there, and it should be between 120 and 200 milliseconds, or 0.12 and 0.20 seconds, and it's 3 to 5 millimeter small boxes. The QRS should be less than 120 milliseconds, or 0.12 seconds, or 3 small boxes. It turns out normal is less than 100 milliseconds, or 2.5 small boxes, or 0.12 seconds. Now, the wide QRS can be an indicator of conduction system abnormalities, such as bundle branch blocks, abnormal depolarization, severe LVH, ventricular arrhythmias. So you want to pay attention to this. Now, the QT is an interval which we mentioned that begins with the QRS and goes to the end of the T wave, which sometimes is difficult to differentiate from the U wave, and again is complicated. Roughly, you want to know that 450 milliseconds, or 0.45 seconds at a normal rate, is normal. It turns out that at normal rates, roughly 60 to 90, the QT interval should be less than half the RR interval as we see here. And that is something you can rely on. Now, at faster rates, it doesn't work as well. So left bundle branch block. This is really, for me, a morphologic diagnosis. You can do vector cardiograms, you can be fancy. It should be greater than 120 milliseconds. It has a broad monophasic R wave in 1 and in V5, V6, which is usually notched or slurred, and we call that rabbit ears up. And there is an absence of a Q wave in the lateral precordial leads, and it causes a repolarization abnormality of ST wave abnormality, which is depolarizes in the opposite direction of the QRS. Now, this would be an example of it. Notice I'm just going to go over some of the systematic approach to EKGs. The standardization is there, 10 millimeters, 250 millimeter paper, 25 millimeters per second paper speed. So we see that this is nice and regular. We have a rate of 1, 2, 3, 4, 5 boxes, so roughly 61 beats. We could count them all the way through. We have a PR interval that's normal, a QRS that is wide. It says up here that the wide is 142 milliseconds. But notice that the QRS in lead 1 is notched, and this is consistent with a left bundle branch block. Notice in lead V5 and V6, it's notched there, suggesting a left bundle. And then if you look at the QRS in lead V1, it doesn't have that same notching, but it is still wide. Notice also that the QT here is less than half the RR. All right, right bundle branch block is an interesting one. And again, morphologically, the QRS is greater than 120 milliseconds. There is an RSR prime in V1 and V2, and there is a wide slurred S wave in 1 and V5 and V6. Here, let's see that EKG. Now, again, we looked at the standardization here. We see that the rate is 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So 10 times 6 is going to be a rate of 60. We looked at the, there's an upright P wave here in lead 1 and 2, and it's negative in AVR, and there's a P with every QRS. So this is sinus rhythm. In addition, you can see that the axis is normal. It's up in 1, it's up in 2, so it's normal. There's no axis deviation. And notice that the PR interval is less than 200 but greater than 120. Now the QRS is wide. Again, it's wide and greater than 120 milliseconds. And it has a deep slurred S wave right here, and it has an RSR prime, and it has a deep slurred wave here. And if I show you this, notice that deep slurred S wave there, and over here we have another S wave, but here we have an RSR prime. So this would be right bundle. Now it turns out that if you take the EKG and you rotate it 90 degrees clockwise, the use anesthesiologist taught me this, that if you notice, if you were to turn this laptop or whatever on its side, lead V1 right here points to the right, whereas in left bundle branch block, it points to the left. And we'll see this on this next cartoon, which shows left bundle branch block, notched QRS in lead 1 and in V6, but a deep S wave in V1. If you turn this clockwise, it would point to the left. In addition, if you look at right bundle, here we have that S wave here, that slurred S wave. We have the slurred S wave here, and we have this RSR prime here. And that, if we turn the paper 90 degrees clockwise, lead V1 points to the right, whereas, as you see, lead V1 in left bundle points to the left. That's just a little trick. Again, don't rat me out to the cardiology community for being too simple. All right, morphology is probably the largest and most important part of the EKG because that's where we see big-time diseases such as heart attacks, pericardial effusions, Wolff, Parkinson, White, all of the OMG or oh my goodness EKGs that you want to not miss. So we look at the PQRS T waves. Do they look normal? P waves should be upright in 1, 2 in AVF and negative in AVR. Otherwise, you want to think that it's an ectopic rhythm. The QRS should be normal width. We've seen left bundle, right bundle. The ST segment should be the same at the same level as the PR segment, not depressed or elevated. And the T wave should not be peaked or flattened or inverted. And then last but not least, you want to look for abnormal waves such as the Q wave or delta waves, and there are other abnormal waves on the EKG that are more advanced. So when we look at the atrium, we look at the P wave, and the P wave with left atrial enlargement is going to be long, 3 millimeters wide, and in lead V1 or in lead 2 it's more easily seen to be 3 millimeters wide. We call this P mitrale or left atrial enlargement. It should be 1 millimeter wide and 1 millimeter deep in lead V1. Now, the P wave frequently in right atrial enlargement means that in lead 2 it's very tall. It should be 2.5 millimeters tall in height, and it should have 1.5 millimeters tall in lead V1. Now you notice that I used millimeters instead of millivolts, but if you wanted to be more precise for a case write-up, you would just say that these are 0.25 there in the height, 0.25 volts, millivolts, and here in the V1 it would be 0.15. So, all right, this is a nice summation of all of the atrial abnormalities that you might see. Sometimes these can be precursors to atrial fibrillation. Sometimes we see mitral stenosis with left atrial enlargement. Pulmonary hypertension and chronic lung disease can give you right atrial abnormalities. So you'll see some of these. Now, hypertrophy. There are lots of ways to look at hypertrophy and probably over 15 algorithms for it. But what I found is that there are 5 basic points that you look at with hypertrophy, and that would be, is there left axis deviation? 1. 2, is there left atrial enlargement? 3, is there a big S wave demonstrating depolarization away from lead V1, hence left ventricular hypertrophy on the left side? And then, is there ST segment changes that suggest hypertrophy? Sometimes we refer to these as a repolarization abnormality or strain. Now, the Romhild-Estes criteria use this same concept. It gives a scoring system of left atrial enlargement, left axis deviation, the QRS may be widened, and it has a big R or S in the leads, S in V1 or V2 greater than 30, or an R in V6 greater than 30. So it uses all of those criteria. Now, there are lots of other criteria, the Cornell criteria and various other ones. Now, right ventricular hypertrophy is just the opposite. You get right axis deviation, you get right atrial abnormality, you do get a little widened QRS, you get a tall R wave in V1, not a big S wave as in LVH, so a tall R wave greater than S wave in V1, because that's the right ventricle is right next to the V1 and V2. Now the deep S wave in V6 is all of the forces are now going away from V6 because of the right ventricular hypertrophy, so you get a S greater than R in V5 and V6. So it's just the opposite. Here's what I put in there for you just as a rough table. But again, left axis, left atrial enlargement, big S wave, big R wave, and strain repolarization abnormality. I'm just going to show this example of LVH, but the same is true. You could have right atrial abnormality, right axis deviation, R greater than S in V1, S greater than R in V5, V6, and 2, 3 in AVF. Now, this is a great example of a person who has all of those qualities of LVH. First of all, you can see that the standardization is normal, and the height and the paper speed. So this is a rate of 1, 2, 3, 4, so rate of 75, or you could count them across. It's sinus rhythm with an upright P wave in 1, 2, and negative in AVR. There is a P wave before every QRS. And in addition, we're looking at the axis. So the axis is positive in 1, negative in 2. So we have left axis deviation. And in addition, we look at the morphology. We're looking at the intervals are all normal, except the QRS may be a little bit wide, which you can have in LVH by Estes criteria. PR is normal, but this pattern right here of ST segment depression in 1, and also inverted T wave in AVL, and ST depression here is all consistent with the repolarization abnormality of LVH. Now, there are other criteria that we have. The Sokolow-Lyon, greater than 11 millimeter R wave in AVL. We have the Cornell criteria that has R wave in AVL plus the S wave in V3, greater than 27 in men, greater than 21 in women. We see big voltage here in S waves, not so much in the R wave over here, but the one that I really want you to focus on, these ST changes, these repolarization changes, which could represent ischemia if it was new onset and wasn't there the day before, but this has longevity, and this demonstrates the importance of finding an old EKG. So let's move on to the next one. RVH, I didn't put anything there, but we were going to use some terminology on findings in morphology. For example, when we look at injury or damage to the heart, we call that acute myocardial infarction, and we see ST elevation in at least 2 contiguous leads. Now, what is a contiguous lead? The contiguous leads mean that it's either 2, 3, and AVF are contiguous leads, or 1 and AVL are contiguous leads. V1, V2 are contiguous leads. V3, V4, V2, V3, V4, V5, all of those are contiguous leads. And if there is ST segment elevation in those leads, you want to be thinking in the setting of chest pain that they are having an acute coronary syndrome, an acute coronary injury, and if there are Q waves, myocardial infarction. So we also notice that in 2, 3, and AVF in the limb leads are going to have reciprocal changes of ST segment depression in the other set of contiguous leads. So let me just repeat that. So if I have ST elevation in 1 and AVL, I will expect ST depression in 2, 3, and AVF. Likewise, if I'm having an anterior infarction in 1 and AVL, I'm going to expect ST depression in 2, 3, and AVF. So those are reciprocal changes. Now, you're going to hear the term ischemia, and that usually implies ST segment depression or T-wave inversion. And these can be dynamic ST changes. So you will hear terms like non-ST elevation MI, in which you have enzyme damage in the blood levels or cardiac biomarkers, and yet you have dynamic ST changes in T-wave inversion or things like that. But this is not the same as a STEMI, ST elevation MI, which we see elevation implying injury, and it implies a transmural cardiac event, transmural damage. Now, we oftentimes will hear if there are significant Q waves of greater than 30 milliseconds or about 1 millimeter of length to the Q wave, or if it's 25% of the following QRS, then we call that a significant Q wave and implies infarction. Now, ischemia implies impaired blood flow, but not lack of blood flow. It's manifested on the EKG as ST depression. It does not localize the region of the myocardium as well as ST elevation. It can be seen, as we've seen already, with left ventricular hypertrophy. We can see it with digoxin effect, and we already have seen ST changes with repolarization abnormalities with the bundle branch blocks. We can see T-wave inversion also with strain, hypertrophy, and bundle branch blocks. So you'll sometimes also hear nonspecific ST wave abnormalities, which we won't pursue further here. So a Q wave is an initial negative deflection of the QRS. It's felt to be significant, as I mentioned before, if it's a 1 millimeter wide. Some people feel if it's 2 millimeters deep, but also it can be a quarter of the QRS complex. It may represent a myocardial infarction in the past, particularly if it has to be in 2 contiguous leads. Now, the ST segment has a lot of other diseases associated with it. The most important we obviously have mentioned, which is acute ST elevation myocardial infarction. But we also know that it can be seen in athletes, 22-year-olds with early repolarization. We said that it can be seen in the context of middle-aged or older people with ST elevation and chest pain, which might imply a myocardial infarction or damage. We can see it with an old ventricular aneurysm. We can see if it's global, if it's in all of the leads and not just reciprocal changes as seen in acute MI. We're going to see pericarditis. You can sometimes get myopericarditis, which can be seen with smallpox vaccinations. Usually we don't see ST segment elevation to hypertrophy, but we can see it in bundle branch blocks. And oftentimes bundle branch blocks can be, particularly left bundle branch block, can be the end point of left ventricular hypertrophy. Now, severe neurologic catastrophe, trauma, subarachnoid bleed should always be present or looked for in patients with STT abnormalities. And sometimes these will be associated with QT prolongation as well as deep, broad T waves. Coronary spasm or stress cardiomyopathy can also have ST elevation mimicking a myocardial infarction or transmural ischemia. Now, the American Heart Association has set up these diagram, which was borrowed here, and it demonstrates that a lateral MI or a LAD occlusion will give you ST elevation in 1 and AVL, but it will also give you septal infarction here in V1 and V2, and V3, V4 is anterior, and V5, V6 is lateral. So you can see on this diagram that the left anterior descending artery comes down here and it hits the septum, the anterior wall, and the lateral wall. So this is a major league infarction. Now, the inferior leads, in other words, 2, 3, and AVF, which we showed on the axis, can sometimes imply that there is inferior infarction here on the bottom side of the heart, and sometimes can go all the way to the posterior part of the heart. Now, we look sometimes for ST depression with posterior MIs in V1 and V2, or if we put them around and we do V7, 8, and 9, posterior leads on the back of the heart, we can also look for posterior wall infarction. Now, sometimes with inferior MIs, we put right-sided leads. As I mentioned earlier, we have the left-sided. We just switch them mirror image to the right side, and we look at V4R for right ventricular infarction. Now, so this is an example of an EKG that we have here, and notice how we have ST elevation in 2, 3, and AVF, and in addition we see the reciprocal changes in AVL and lead 1. So this would be a inferior myocardial infarction. We already have Q waves present along with that ST elevation, and this involves the right coronary artery. I'll show that in a minute. And then we also look at changes in the anterior leads, which we don't see. Now remember, we were systematic. We have the standard here. The P wave is upright in lead 1 and negative in in R and positive in 2. So that's sinus rhythm. The rate is about 75. The axis is upright in lead 1 and lead 2. The intervals appear normal, and the morphology of the P wave looks normal, of the QRS looks normal, and the ST elevation, though, is present, as we mentioned, and Q waves are also present.
This is a complicated diagram that I wanted to show to you because it gives the basic anatomy not only of the cardiovascular aspect, but also the electrophysiologic aspect. We have the SA node at the junction of the right atrium and SVC, and it has its 3 internodal pathways as well as a little Bachman's bundle to the left atrium, and it goes to the AV node, and then the AV node, it goes through the bundle of His down into the right bundle, which depolarizes the right ventricle, And the left bundle, which has two other fascicles with it, called the anterior fascicle and the posterior fascicle, which is pertinent towards conduction abnormalities, which we refer to with our axis deviation as left anterior fascicular block and left posterior fascicular block. Note also how the right coronary artery feeds the inferior wall of the heart, and the left anterior descending artery feeds the anterior part of the heart, the so-called anteroseptal, anterior, and lateral parts of the heart.
Let's do a couple more. 13, 14, 15, 16, 17, 18, 19. So 19 times 6 is going to be about 110. So now we're going to look. We have a sinus tachycardia. You see the P wave that's upright in 1, 2, and negative in AVR. We look at the intervals here, or we actually look at the axis is positive in 1, positive in 2, so it's a normal axis. Then we can look at the intervals, the PR, the QRS looks normal, the QT we're not certain, but it looks like it's about half, and at a fast heart rate we're not too worried about that. And then what we are worried about is we're seeing huge ST elevation here in 1 and AVL, right? And we're also looking at reciprocal changes of ST depression in 3 and AVF. And then over here you're saying, well, this ST elevation doesn't look very big. But remember, at 1/2 standardization, these are twice. So this is 10 millimeters of ST segment depression here. We go from the above the PR segment to the J point, not to the T wave. We look to the J point here, and that gives us a evidence of an anterior, anterolateral, anteroseptal myocardial infarction. So this makes a big difference. Now the clinical context, you probably said we already knew that he was having chest pain and he has diabetes and hypertension, the pretest likelihood. So you probably had the diagnosis even without the EKG, but this tells us what type of heart attack he's having. And this would be a transmural anterior MI. Now the next one is a 51-year-old woman seen in the emergency room for chest pain. So right away, your pretest likelihood for chest pain, you're going to make the diagnosis, but let's be systematic. We look at the standard, we don't see it. We look at the rate, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. So 11 times 6 is rate of 66. We're going to look at the whether it's sinus rhythm, upright P in 1 and 2, negative in AVR. So that tells us that it's sinus rhythm. Then we look at the axis. It's positive in 1, it's positive in 2, normal axis. Then we look at the intervals. PR is normal, QRS is normal, the QT is less than half the RR interval at a normal rate. And then we look at the morphology. The QT is normal. But this time we see ST depression in 1 and AVL. But we look in the contiguous leads and we see ST elevation in lead 2, lead 3, and AVF. So we're saying this must be a right coronary artery inferior myocardial infarction. Now you might say because there aren't Q waves here, you could say, well, this is just injury. But we know that it's not pericarditis. We know from the history. So you have all of that information, and this person needs to be taken either to the catheterization laboratory or it needs to be taken to the given lytic therapy, and after assessing the clinical context. So there, now you have the end of the EKG. Have fun with those other tracings. Try and remember, 1, be systematic. 2, clinical context. 3, find an old EKG, which you don't have with all of them. And then watch out for bad data. And you'll have plenty of help with your instructors. And again, remember that you are the best thing to happen to medicine, and have a great time on the wards. Come by and visit anytime and introduce yourself. Bring me by any EKGs that you find interesting, and thanks.